Hey everybody, it's Jeff Solheim, and hope you're all doing good. I know I am. We're just working on all the logistics of getting the PowerPoint up and running. Um, so give us about 10 or 30 seconds, and we'll hopefully have this all ready to go. But while we're working on that PowerPoint on the other side of the screen, I wanted to welcome everybody. I'm sure many of you are like me. Um, uh, Wondering what all is happening. As some of you know from my Facebook posting, I just got back from vacation, so I only had my first shift at work this weekend. But um, all the same, it brought a little bit of anxiety going back to work. However, once I got there, I don't know, it just felt like another day at work, perhaps a little bit more stressful than usual. So this is my chance to say thank you to everybody for everything you're doing. And recognizing that these aren't easy times for anybody, but especially for healthcare workers. So, with that being said, I want to do a presentation here today on mechanical ventilation, and I want to make sure I understand, or you understand, that we're going to do just a very basic overview. Only have 30 minutes to do, a really good review of ventilators. Would take a few hours. So I'm not going to make a respiratory therapist out of any of you. The nice thing is we have respiratory therapists, but I hope that as you think about the possibility of having to hold patients in the emergency department in the coming uh, weeks, that just a little bit of core knowledge about ventilator management might help you better understand, um, what's happening, and be able to talk a little bit more intelligently with our respiratory therapist colleagues. So all I'm going to do today, because we only have a half hour, is I'm going to go over the four basic ventilator settings with you that really you need to know to kind of understand and work along with your patients who have it. And I'm going to try and specifically bring a few of these settings back to caring for the patient with COVID from what we understand from both our colleagues in China as well as Italy that are a little bit more ahead of us in caring for some of these patients. So I'll tie some of it back. But just so you know, and I'll talk more about this at the end of the lecture, we're also going to be posting a free recorded webinar on ventilator management that will be a little more in depth than mine. The recorded one will actually get into some of the different ventilator settings, and actually allow you to do some case studies that take blood gases, and let you apply some of these things. So it'll take it a little bit further than what I'm giving you today. However, the one that we're going to be posting online was actually filmed before the COVID crisis, so there's no actual specific references to COVID in the recorded one. So I'm hoping between watching what I'm going to do today, which will be a little more COVID specific, and then going and watching the more general one online a little bit later, you can feel a lot more prepared to care for patients who might end up being held in your emergency department with COVID on a ventilator. So with that being said, we're going to get this started, and we're going to advance the slide now. The first thing that I want to do here is I'm just going to give you a question, and then we're going to go through the material, and then we'll answer the question at the very end. All right. So the question reads: a patient with acute respiratory distress syndrome. Now, you could, if you want to, you can substitute that with a patient who has ARDS secondary to COVID, is on a mechanical ventilator with the following settings. So the FiO2 is set at 80%, the respiratory rate at 12, the tidal volume at 5 mils per kill or 300 mLs, the peak end expiratory pressure or PEEP at 15 centimeters of water. Now, with those settings, the patient's blood gases are as follows. The pH is 7.33, the PO2 is 84, the PCO2 is 77, and the bicarbonate is 16 millimoles per liter. So with that information, which of the following changes on the ventilator would be most appropriate at this point? Would you increase the FiO2, decrease the tidal volume, increase the respiratory rate, or decrease the peak end expiratory pressure? And I'm going to let you kind of think about that one for a moment. Um, and certainly and you guys can't chat directly with me, but you can put your comments below. So see if you want to throw in your answers to this, and then I'll go through the material, and then hopefully at the end I'll give you the question again. It should be pretty obvious. I think you'll be able to answer it no problem. But if you want to just think about it a little bit. I know the writing's a little bit small on the screen, but if you can read it, see if you can come up with the answer. Do you think it's A, B, C, or D? Let me read them again. Would you increase the FiO2? A. Would you B, decrease the tidal volume? Would you C, increase the respiratory rate? Or would you D, decrease the peak and expiratory pressure? All right. Well, I see some answers coming in. So I'll let you keep answering. I'm going to keep moving just because of time. We'll move on to the next slide, but you're welcome to keep answering it, and we'll be watching for your answers. All right. So as I said, today, because we only have, I don't know, 30, 40 minutes, whatever I can do this in, I'm not going to be able to get really, really deep um, in to, what do you want to say? I'm not going to be able to get into like um, SIMV versus IMV and pressure control and all that stuff. While that's information may be somewhat useful, I think today where I really want to focus is on the 4 basic ventilator settings: FiO2, PEEP, respiratory rate, and tidal volume. And we're going to talk just specifically about those, how to set them, and then how you might adjust those with people who have the COVID virus or complications related to it. So with that being said, let's just keep moving forward to the next slide. And while we're moving forward, I can see that a lot of you are already answering it. The uh, the 4 ventilator settings we're going to talk about today, as I just said, are FiO2, respiratory rate, tidal volume, and PEEP. Now, what you may or may not be aware of is that 2 of those settings are specifically designed to alter or to help assist a patient who has a low PaO2, and 2 of those settings are specifically designed for people with an elevated PaCO2. So when you're looking at your ventilator settings, both setting them initially when the patient's first intubated and then adjusting them after the patient's intubated, you really want to do this according to your patient's blood gases. So you look at the blood gases and you say to yourself, is my patient's problem a low PaO2, or is my patient's problem an elevated PaCO2, or is my patient's problem both, or is my patient's problem neither? And based on those answers, then you're going to know which of the ventilator settings to adjust. So I'm going to ask you guys, which of the, or let's start with FiO2. Is the FiO2 meant to manage a low PaO2 on blood gases, or is it meant to manage an elevated PaCO2? Okay, so the FiO2, which one is that one for? Low PaO2 or elevated PaCO2? Now, this, of course, is not a very, very difficult question I just asked you. Go ahead and type in the answer, but I'm going to go ahead and give it to you while you type it in. I'm sure most of you guessed, and we can advance the slide one, that a low FiO2, I'm sorry, a low PO2 is treated by altering the FiO2. So FiO2 is meant specifically to alter the PaO2. Now, what about respiratory rate? Is respiratory rate meant to alter PaO2s or PaCO2s? Which are you going to get your bigger bang for your buck with a respiratory rate? Low PaO2 or low or elevated PaCO2? What do you think? Give you a second to think about it. Is it a PaCO2 or a PaO2 intervention to change the respiratory rate? Well, go ahead and advance the slide. If you picked elevated PaCO2, pat yourself on the back. Respiratory rate is mainly meant to work with your PaCO2s. So when your patient's blood gases show a problem with PaCO2, you're going to look at changing the respiratory rate. Now, the third one is tidal volume. Is tidal volume meant mainly to affect PaO2 or PaCO2? Which side? What do you think? Go ahead and type in your answer. Again, let me ask the question. Tidal volume, is that meant more for PaO2 or PaCO2? What do you think? Well, I see lots of answers coming in, but I'll go ahead and give it to you. If you said that tidal volume, we can advance the slide, is on the PaCO2 side, pat yourself on the back. You got it right. Now that leaves us with PEEP. Is PEEP mainly meant to alter PaO2 or PaCO2? What do you think? PEEP, peak end expiratory pressure. Is that a PaO2 or a PaCO2 thing? What do you think? Give you a minute to answer in the comment section below. And while you're answering, I see lots of answers coming in. We can advance the slide. PEEP is meant for the PaO2 side of things, okay? So overall, when you're gonna put a patient on a ventilator or you're going to adjust their ventilator settings, you need to look at the blood gases. Does the patient have a PaO2 problem? If they do, it's likely PEEP and FiO2 that you're gonna alter. Whereas if your patient has a PaCO2 problem, then it's tidal volume and respiratory rate that you're going to alter. Okay. So it's kind of a general rule of thumb, and we're going to be able to apply this as we go. So, what I want to do now is take and look at each of these just a little bit deeper, how they affect and how you would adjust accordingly. So, let's go ahead and advance the slide. So, again, here's the four basic settings um, FiO2, tidal volume, respiratory rate, and PEEP. And let's look at each of these in a lot more detail um, one at a time. So let's start with FiO2. So um, the FiO2, as you probably know, is the inspired percentage of oxygen. So if we advance the slide, um, the fracture of inspired air, FiO2, is just simply telling you how much oxygen you're driving into the ventilator circuit. Um, and then obviously what's driven into the ventilator circuit will end up in the alveoli. So as you I'm sure know that room air is 21% oxygen and then about 79% nitrogen, right? So if I don't put any oxygen into the ventilator circuit, I'm going to give my patient 21% FiO2 because that's room air. But if I want my patient to have more oxygen against the alveolar surface, I just simply need to increase the FiO2. And by increasing it, I'm simply adding extra oxygen into the circuit that'll end up going down into the alveoli. Okay. So if we advance the slide, your FiO2 again, generally FiO2 is 21% on room air, but we can increase it by adding more oxygen and by adjusting the FiO2. Now, as you might know, a lot of times on your ventilator, and even when we talk with respiratory, rather than uh, talking about these in percentages, we talk about these in percentage points. So when I'm talking about giving somebody 40% FiO2, you may see it written as zero point 0.4. Just depends on your ventilator and so on, but you can see the FiO2 expressed as either a percentage or a decimal point. But all that's telling you is how much oxygen is being added into the circuit. And then when that's added into the circuit, it then, of course, ends up in the alveoli. And it should be obvious, but the more oxygen there is hitting the alveolar surface, the more oxygen is going to perfuse across the alveolar membrane and end up in the blood. And the more oxygen there is in the blood, the more can be delivered to the cell, right? So obviously, FiO2 is going to directly impact a patient's PaO2 because the more oxygen you put into the alveoli, the more that ends up in the blood. The more there is in the blood, the higher the PaO2. Okay, so FiO2 is meant to specifically affect PaO2. So if we advance the slide, um, normally when you're intubating somebody and in say in an emergency setting, we usually are intubating them because the patient can't maintain their own oxygenation. So it's not uncommon when we intubate somebody that we just start them at an FiO2 of 100%, right? That means that there's no nitrogen at all in what's being delivered. Everything being delivered into that ventilator circuit is oxygen. And so all the oxygen's hitting the alveolar surface, and then all that oxygen is diffusing into the blood, and you're flooding the hemoglobin with oxygen that can be delivered to the cell. So most of the time when we intubate, we a sick patient, we start at an FiO2 of 100. And then we adjust that FiO2 based on the patient's blood gases. So we intubate them, and then 30 minutes later, 45 minutes later, we do a set of blood gases. We look at the PaO2. If the PaO2 is really high, we can lower that FiO2 down until we find the level that's needed to maintain the patient's blood gases. Now, your perfect FiO2. So when you're looking at reducing your FiO2s, you're going to reduce them according to the patient's blood gases. And your goal is an arterial oxygen saturation greater than 90% and a PaO2 greater than 60. Okay, so you can keep bringing those FiO2s down and then look at your blood gases, and your goal is those particular parameters as a minimum. Those would be minimum parameters that you look at. Obviously, we'd like those a little bit better, but those are the minimum parameters. So if you start dropping your FiO2 down and those parameters go lower, uh, then you'd need to put your FiO2 back up. Now, if we advance the slide, I want to spend a minute and talk about the dangers of FiO2, because it would make sense that if you were going to use FiO2 to elevate everybody's PO2, why don't we just set everybody at 100% when they come in, flood their hemoglobin with oxygen, and they'll be fine. They'll survive, supposedly. But it's not that easy. There's a couple of problems with FiO2. The first one is oxygen toxicity. Now, on the screen, I've given you a fairly detailed drawing of oxygen toxicity, but I'm going to try and simplify what's on the screen. What is oxygen toxicity? Basically, when your cells use oxygen, they produce waste products. Now, normally, there's antioxidants within the cells that get rid of those waste products. So, we use the oxygen, waste is develops, then we get rid of the waste through the antioxidants. And if you're breathing in 21% oxygen, your cells are pretty good about getting rid of all those waste products. But when you start getting your FiO2s above 40 or 50%, the amount of waste product produced in each cell by that excess oxygen will exceed the amount of antioxidants available to get rid of the waste product. So let's say you're giving somebody 70 or 80% FiO2, those cells are producing way more waste product than they can get rid of. And the cells begin to swell as they fill with waste product that we can't process. And if the patient remains long enough on those high levels of oxygen, the cells can swell to the point of rupture. And then when they rupture, of course, they die. And because mostly it's going to be in the airways that you're going to see this excess oxygen and this swelling of the cells in the airway are going to rupture and die, and then the dead cells are going to start to slough off, and the lower airways can begin to fill with cellular debris, and you can actually block off the lower airways. Now, in really high FiO2s, say an FiO2 of 100, you can start to see significant oxygen toxicity in as little as 24 hours. If you're using lower FiO2s, it may take longer for these negative effects to develop, but you are going to begin to see the death of cells along the airways, and then the atelectasis in the lower airways as they become as the dead waste products begin to accumulate in the lower airways and block them off. So for that reason, we're limited in how much FiO2 we can use, especially for a long period of time. You can start somebody on FiO2 of 100, but you can't leave them there for the rest of the time in ICU, or you're going to create a whole new set of problems in this whole oxygen toxicity realm. There's another problem that goes with high FiO2s, and let me talk about that. We'll advance the slide. The other problem that we can see with these high FiO2s, before I get into the other problem, this slide just talks about some of the negative effects of oxygen toxicity. So if your patient remains on high FiO2s for too long, they can get into oxygen toxicity, and here's some of the symptoms of oxygen toxicity. Decreases in inspiratory and expiratory lung volumes, decreases in flow rates, decreases in carbon dioxide diffusing capacity, decreases in lung capacity, and increased susceptibility to mucus plugging, atelectasis, and secondary infections by impairing mucociliary clearance. Now, does that not sound a little bit like what our patients with COVID develop? Yeah, it does, doesn't it? All right, let's advance the slide. I want to talk about one other problem with high FiO2s. So let's say you put somebody on 100% FiO2. Before we get into the high FiO2s, let's just talk about what's happening normally in the alveoli when you're not on a ventilator. So when you're not on a ventilator, you're breathing in room air. Now remember, as I said earlier, room air is 21% oxygen, 79% nitrogen, right? Now only oxygen diffuses across the alveolar membrane. Nitrogen doesn't. So when you breathe in room air, 21% of the volume of the alveoli is going to cross the alveolar membrane and go into the hemoglobin. But the 79% nitrogen stays in the alveoli and holds it open. So your alveoli actually stay open because there's 79% nitrogen in there that doesn't diffuse. Now think about what happens when you put somebody on 100% O2. So you intubate them, you put their FiO2 at 100%. Now, what's going to diffuse? Remember, oxygen diffuses, right? So if you're putting somebody on 100% O2, everything's going to diffuse. There's no nitrogen left inside the alveoli, right? So when you put in 100% O2, all the oxygen diffuses, And then that causes the alveoli to collapse because there's no nitrogen left to hold it open. That's called nitrogen washout. Now, remember as well that your surfactant is sticky. So every time that that alveoli completely collapses with the FiO2 of 100, the ventilators got to force that alveoli back open by forcing that sticky surfactant to release so that the alveoli can open. And for a period of time, that may work. But over time, if you have somebody on an FiO2 of 100, when those alveoli begin to collapse and stick together, they won't open again. And so now you begin to develop an atelectasis and you get these non-working alveolar units that are stuck shut because there was no nitrogen to hold them open. So that's another problem with our these high FiO2s is this nitrogen washout and this atelectasis from your alveoli collapsing. So if I kind of review this, 100%, or I mean, FiO2s of like 100% are really high seem to be the answer to fix everybody's PaO2. Put in a ET tube, and then put them on a ventilator. Put them on 100% O2. Before long, you're going to have great SATs and great PaO2s, and your patient's going to improve. And that might seem like the answer, but 24 hours later, your patient's going to begin to develop atelectasis from nitrogen washout and from oxygen toxicity, and now you're losing the battle. So FiO2 is not the only answer. It's only part of the answer. So what's the other thing that we can rely on when it comes to PaO2s? PEEP, right? We said that at the beginning. The two things that'll affect your your PaO2s are FiO2 and PEEP. So FiO2 is a temporary solution. It can fix things quickly, but it's not a permanent solution because of the problems. So we have to rely on PEEP as well. So let's advance the slide. So what is PEEP? Oh, I guess we're not going to do PEEP right now. We're going to do tidal volume because that's what's next on the slide. So hold on to the PEEP thought. I'm going to come back to it. Let's do tidal volume because that's next on the slides. So as you might recall, tidal volume is the amount of air that is put in with each breath. I'm overall, an average adult breathes about 300 mLs of air per minute. It depends upon how much you weigh and how big your lungs are, but on average, we take in about 300 mLs of air with each breath. That's the tidal volume. It's the amount of air you move in and out during a normal breath. Okay. Now, as you might remember from when I started this, I told you that your tidal volumes are meant to affect PaCO2s. How? Well, think about it. If I put in more air, I'm going to breathe out more air, right? So if you put in more is going to come out. And if more comes out, what comes out with air when you exhale? Carbon dioxide, right? So if you turn up your tidal volumes and deliver more air with each breath, your patient will exhale more and that'll bring more CO2 out. So that's why your tidal volumes are great for people who have CO2 issues. If you look at the blood gases and the CO2 is elevated, turn up their tidal volume, right? All right. So let's advance the slide. Now, just talking about what is a normal tidal volume. As I said earlier, normal tidal volume is about 5 to 8 mLs per kilogram of ideal body weight, not actual body weight, but what you would weigh if you were the perfect size for your skeleton. Okay. Now, just so you know, when we're working with ventilated patients, we usually use a little bit of a higher tidal volume than normal. Why? Well, because the ET tube and all the tubing that goes to the ventilator, the oxygen in the ET tube and the tubing never reaches the lungs. So that means that all of that volume in the tubing is not being transferred to the hemoglobin. So I have to account for that extra dead air that never gets down there. So I'm going to use a little higher tidal volumes on a ventilated patient than I would if they weren't ventilated. Normally we breathe about 5 mLs per kilogram of ideal body weight without a ventilator. On a ventilator, we often consider 6 mLs per kil to be kind of normal. And that extra bit makes up for the dead space in the tubing that never reaches the lungs. Okay. So I'm going to give you some mathematical calculations. You probably don't need these, but just so you know what our RTs are doing when they're figuring out tidal volume, if we advance the slide, you can see how we set tidal volumes. Again, there's apps that do this, and we can often do this in our head when you intubate as much as as some people do. I mean, as a flight nurse, I'm intubating all the time. So these are things you can do in your head, but you can also calculate to figure out a tidal volume. So in men, the and women, you can see on the screen the calculation that you can plug into your phone or whatever you're using to figure out what the tidal volume would be for a patient. That's getting pretty specific. When I'm intubating somebody, I kind of eyeball them. What do they look like they weigh? I multiply that by 6 and I kind of figure out what the tidal volume should be. But those are the mathematical equations on the screen that you can use if you want to be really exact. And then we end up rounding it up anyway. So if we advance the slide one more time, this guy on the screen will say he's supposed to weigh 80 kilograms. We want to get 6 mLs per kill as his tidal volume. That's normal, remember. That would be kind of considered a normal tidal volume. If the PaCO2 is perfectly normal, if it's between 35 and 45, and we don't want to adjust it, I'm probably going to give him a tidal volume of about 6 mLs, give or take. So if I take 80 times 6, that means that he should get a tidal volume of about 480 mLs. So I'll probably round that up and give him a tidal volume of 500 mLs. Now, if that same guy weighs 80 kilograms, but let's say his CO2 is really high and I want him to blow off more CO2, well, I might turn that tidal volume up to 10 mLs per kill. So 80 times 10 is 800 mLs. So I would turn my tidal volume up to 800 mLs, and that would help him blow off more CO2 temporarily. So that's how we can use tidal volumes to adjust the CO2. So let's advance the slide for a moment. So it should be obvious then how we use tidal volumes. Tidal volumes are simply the amount of air that we breathe in. The more you breathe in, the more you breathe out. The more you breathe out, the more CO2 comes out. So I can use your tidal volumes to increase or decrease CO2. If CO2 is low, I can turn down the tidal volume. If CO2s are high, I'll turn up the tidal volume. But then my patient can breathe different amounts. Again, that seems easy, but there's problems with tidal volumes, and they should be obvious, especially when you're caring for the COVID patient. So this is where I'm going to go into COVID a little bit. But can you think about it? What is the problem with tidal volumes, right? Um, so the problem with the tidal volume is that the lungs, the alveoli can only stretch so far. So I can keep giving more volume, but at some point, if the volume gets too much, the alveoli is going to rupture, right? Now, in a young, healthy athlete who's got really healthy lungs, we can stretch those a long ways. And I can use really high tidal volumes, like 10 or maybe even 12 mLs per kill. But if I have an older patient whose lungs are already fibrosed, if I have a COPD patient whose lungs are already stiffened, I can't use higher tidal volumes. In fact, 6 may even be a little high for them, and I might have to go a little bit lower. Now, how does this relate to COVID? Because we know that COVID causes an ARDS, an acute respiratory distress syndrome like syndrome, and that stiffens the lungs. So people who have full-blown COVID and are in respiratory failure, their lungs are stiff. And using higher tidal volumes may not be an option, because if you stretch those stiff alveoli, you can rupture them and cause pneumothoraces and other problems. So tidal volume is a little bit limited. Okay, so if we advance the slide, I noticed that we're running out of time, so I'm going to skip a couple of slides here just because of time. So go ahead and move on through this next section. Keep moving, keep moving, keep moving. This you can get in the video we're going to put online. But go back one. There we go. So we've talked about FiO2. FiO2 is the percentage of oxygen you give. The more you give, the more that goes in the blood, and the higher the PaO2 goes. Now we've talked about tidal volume. The higher the tidal volume goes, the more CO2 the patient blows off. So you can use it to alter CO2. Now, again, the problem with FiO2 is oxygen toxicity and nitrogen washout. The problem with tidal volume is rupturing the alveoli, especially if your patient has stiff lungs or non-compliant lungs. So that brings us to the third option, respiratory rate. Now, respiratory rate is also used to alter CO2. So if your patient's PaCO2 is altered, then you're going to play with the respiratory rate. Again, this one's kind of obvious, right? If you go running and you come back from a 5K, you're probably going to be breathing 40 times per minute. Why are you breathing so fast? Because you produced CO2 at the cellular level through anaerobic respiration, and your body's trying to get rid of it. The faster you breathe, the more CO2 you blow off. So if my patient's CO2s are abnormal, I'm going to adjust the respiratory rate. Now, as you know, a normal adult respiratory rate is 8 to 12. So if my patient's PaCO2s are normal, let's say that they're, I don't know, 40 millimeters of mercury, that's what your PaCO2 is, then put them at a normal respiratory rate of 10 or 12. That's all you need. And you can just maintain that CO2 level. If the patient's CO2s are really high, say they're 55 or 60, I'll turn up that respiratory rate and they'll blow off more CO2. The higher the rate, the more the CO2 you blow off. And you're going to use higher respiratory rates for patients with acidosis, especially a respiratory acidosis, but you can use it to compensate on a metabolic acidosis. And we can use that for intracranial injury as well. And we may use lower rates for like asthmatic patients who have narrowed airways. And we want to make sure that there's more time for them to exhale so we don't blow up their alveoli. Now, again, with your COVID patients, they are going to tend to have an acidosis. So we may use a higher rate, but you just have to be very, very careful because as time goes on, they're going to have a lot of debris in the airways, and that debris in the airways can cause a longer exhalation phase. And if we give the respiratory rate too high, then you can end up, if they can't exhale enough, you can end up causing a lot of alveolar distension or high pressures on the ventilator. Okay, so let's advance the slide again. So what is the negative impact of respiratory rate? So before I leave respiratory rate, I just want to talk about the one negative impact. There isn't a lot of negative impacts of respiratory rate. You can just turn it up with one caveat. And that is simply to remember your patient's paralyzed. Okay. If they're intubated, they're paralyzed. And paralyzed people can't actively exhale. They have to passively exhale. Okay. And it takes longer to passively exhale than actively. Again, when I go out running, if I do a 5K, I might breathe 40 times per minute, but when I exhale, my intercostals are forcing the air out. When my patient's paralyzed, they can't force air out. That means they have to passively exhale and the rib cage has to retract. And when it retracts, it's going to force air out. But if they're paralyzed, that's not active, it's passive, and it's going to take longer. Okay, so it's going to take longer to exhale if your patient's paralyzed. Therefore, using elevated respiratory rates, well, you got to be careful on a ventilated patient that's paralyzed because if you get them start turning up too high, they're not going to exhale, and then you're going to end up with really high pressures on the ventilator and either blow it in alveoli, or your ventilator is just going to have high pressures and not give a lot of air each time. Okay, so most of the time, we would say the highest you'd want a respiratory rate to go on a ventilated patient who's paralyzed is about 20 breaths per minute. So, I mean, that's going to help. There's no doubt they're going to blow off more CO2 at 20 breaths per minute, but it's not going to normalize somebody with really high CO2s. If their CO2s are up in that 60, 65, 70 range, a respiratory rate of 20 may not do it. And then you're going to have to mix a respiratory rate and a tidal volume. Okay. And you're going to have to play with both of those because you are limited in how high you can go on a respiratory rate. Now, sometimes, like when I'm flying with a patient, I'm one-on-one with my patient. I'll use higher respiratory rates than 20, but that's because I'm sitting at the bedside and I can carefully monitor the pressures on the ventilator. I can watch to make sure the patient's fully exhaling. If you're not able to do that kind of one-on-one care, and I'm going to guess when the ERs get really busy in the near future, there's not going to be a lot of one-on-one care, that you're going to be limited on how those ventilators rates or those respiratory rates can go on the ventilator. Okay, so that's kind of the big negative of respiratory rates. You're a bit limited on the paralyzed patient. Hope that makes sense. All right, let's advance. The last setting I want to talk about is peak end expiratory pressure, PEEP. PEEP is basically putting air in to the alveoli, or let me say that differently. It's putting oxygen into the alveoli um, when the patient is normally exhaling. So it's a lot more complex than this, but let me oversimplify it for you. Normally, you breathe in on a count of one, you breathe out it for a count of two. So you're only putting oxygen against your alveolar surface for about 1/3 of the respiratory cycle. During the exhalation phase, which is 2/3 of the respiratory cycle, you're not bringing in fresh oxygen. So basically, when you're breathing normally, you're only putting oxygen against your alveoli 1/3 of the time. What PEEP does is it blows oxygen into the ventilator circuit when the patient would normally be exhaling. So it's driving oxygen against the alveolar surface for the whole count of three. Instead of only blowing oxygen during the inhalation phase, it's blowing it down during the exhalation phase. So you're getting really 3 times the amount of oxygen against the alveolar surface. again, that's a bit of an oversimplification, but I hope that helps understand why PEEP is useful for patients with low PaO2s. So when the PaO2 is low, put them on higher PEEP. The higher the PEEP, the more oxygen you're blowing in. The more oxygen you're blowing in during exhalation, the more it's going to cross the alveolar membrane and get onto the hemoglobin, right? So that's what PEEP is when I oversimplify it. And it's just going to increase oxygen levels by increasing the amount of oxygen against the alveolar surface during exhalation. Okay. Now, if we advance the slide one more, um, the we can advance the slide one more. There we go. So let's talk about the advantages of PEEP. I just said the main advantage of PEEP is that you're blowing oxygen down there. You're tripling the amount of time that oxygen's against the alveolar surface, and the higher you put the PEEP, the more oxygen you're putting in. The other big advantage for PEEP is that you're holding those alveoli open, especially if you're using high FiO2s. This can help you to minimize that nitrogen washout we talked about. Because normally, when all the oxygen crosses the alveolar membrane, the alveoli is going to collapse. But if you're peeping somebody, if you're blowing oxygen down in there, you're holding those alveoli open. So they're not closing and sticking shut, and you're helping to reduce some of that atelectasis. It's also a lot easier on both the lungs and the ventilator to not have to pop those alveoli open every time, but instead hold them open by blowing that oxygen in. That's your PEEP. So those are some of the advantages of PEEP. Now, as you've come to learn, every advantage has a disadvantage. So let's talk about the disadvantages of PEEP. Um, so before I get into the disadvantages, this slide just talks about some of the things I just talked about, but PEEP is more likely to be used in diffuse conditions requiring increased oxygen like ARDS. And by the way, COVID does result in ARDS, so you can expect to be using PEEPs for ARDS. For pulmonary edema, we do see pulmonary edemas with a COVID virus and alveolar hemorrhages, which we're also seeing with COVID. But it can be very damaging to use elevated PEEP if there's a localized condition like a pneumonia, because the pneumonia is not going to accept oxygen, which means that extra pressure you're putting in is going to go to the healthier part of the lung where there's no pneumonia and over distend it. So you got to be really careful with PEEP if your patient has a known local problem. PEEP is best for diffuse problems like ARDS or pulmonary edema. Okay, now let's talk about the negative parts of PEEP. So what I tried to do in this drawing you see on the screen is to really get down to what makes a PEEP, I'm going to say, dangerous or less likely to be used in some cases. So normally, when your alveoli are collapsed, during the exhalation phase, when you force air out, right, the alveoli collapse, and that puts less pressure on the capillaries around the alveoli. So blood can easily get around the alveoli when the patient has exhaled, right? And that means when the heart pumps and the right ventricle pushes blood into the lungs, the blood can get around the alveoli easier when they're smaller, when you're exhaled, and get to the left ventricle to be delivered to the body, and that's how we get that oxygen to the body, right? But when you inflate the alveoli and make them full, those capillaries around the alveoli are going to be stretched thin. Okay. And then it's harder for blood to get around the alveoli from the right side of the heart to the left. So during the inhalation phase, and when all the alveoli are expanded, less blood actually gets to the left ventricle because when the right compresses and pushes it into the pulmonary circuit, when the alveoli are distended, the blood can't get around the alveoli to get to the left, so there's less blood getting to the left side. Okay, it gets pushed back into the right side, and so if you have less blood going into the left ventricle, that's going to cause a decrease in blood pressure. So the problem with PEEP is if you never let the alveoli fully collapse, you're always keeping them partially opened by putting oxygen in during exhalation. And if they're partially opened, then there's no time where the right ventricle can easily push blood to the left, and the left is going to have a decreased filling, and your blood pressure is going to drop. Okay, so that's the negative impact of PEEP, is it has a negative impact on the cardiovascular system, especially the blood pressure. Now, if you're caring for a critically ill patient whose blood pressure already sucks, putting any PEEP on them can take a low blood pressure and bottom it out. And now you've created a whole new problem, because it doesn't matter how much hemoglobin you deliver to the hemoglobin. Sorry, let me say it differently. It doesn't matter how much oxygen you deliver to the hemoglobin. If there's no blood pressure to push the hemoglobin to the cell, you've gained nothing. So the problem with PEEP is you have to have a good blood pressure, and you have to manage your patient's blood pressure um, in order to be able to use higher levels of PEEP. But if your patient's got a healthy blood pressure, or you can keep it up with either fluids or vasopressors or inotropes, you can get that pressure up, then your patient can probably tolerate higher PEEPs. And that allows you then to use PEEP instead of FiO2 to manage the patient's PaO2 side. Okay. So let's just talk through this for just a moment. Okay. So you have a patient who has you intubate them initially, right? You're going to intubate them, right, and then you're going to put them on an FiO2 of what? If you just intubated them because they were circling the drain, you're going to start the FiO2 at 100, right? Because you just intubated somebody. So we're going to put the FiO2 at 100. Hopefully, that's going to cause a lot of oxygen to cross the alveolar membrane and flood the hemoglobin so that you can increase your patient's PaO2s, and then get the oxygen to the tissue. But we already said you can't leave it there forever. If you start leaving that FiO2 at 100 for more than 4 to 6 hours, you're going to start the patient down that road of oxygen toxicity and nitrogen washout. So what's the option I have to get the FiO2 down? If I want to get the FiO2 down, I need to increase the PEEP, right? If I increase the PEEP, then I can drop the FiO2. The problem is, if you give your patient a bunch of paralytics and other drugs for intubation, their blood pressure may be lower. So I might have to wait for some of the effects of the drugs to wear off. I might need to give my patient a fluid bolus or throw a vasopressor at them, get their pressure up. And then when their pressure is up and I feel confident that their pressure is stable, then I can increase the PEEP, maybe from 5 to 10. Now, I expect that's going to drop the pressure a bit, but if I've stabilized the pressure and they can tolerate a bit of a drop, then we're good. So I'll increase that PEEP maybe from 5 to 10 and decrease the FiO2 from, let's say, from 100 down to 70. Okay. You're playing some guessing games here, but I'll decrease the FiO2 from 100 down to 70. I'll increase the PEEP from 5 to 10 if the pressure is stable, and then I'll sit on it for a while. I'll watch the patient. Does their pressure tolerate that elevated PEEP? If it does, great. If not, I might have to give them a little bit more vasopressor. And then when I feel like they're stable and their gases are good and they're doing good at an FiO2 of 70 and a PEEP of 10, then let's push the PEEP up to 12, and let's drop the FiO2 down to 50, and let's sit on that for a half hour and see how their pressure does and see how their gases do. And if I can get that FiO2 down to 50, I've gotten it down to a manageable level where they're not going to have near as much oxygen toxicity. And but I've got enough PEEP going to maintain that FiO2 or to maintain that PaO2 without a high FiO2, right? So you keep playing. I always think of what my chief flight nurse tells me. He always says, when you're working with a ventilated patient, if you're not adjusting your ventilator every 30 minutes, you're not managing your patient. So it's that constant movement of the blood pressure, the FiO2, the PEEP, and you're managing them all together and looking at the blood gases to try to get the FiO2 at the lowest level possible and the PEEP at the lowest level possible with a manageable PaO2. Now, on the CO2 side of things, again, you can increase the tidal volume as you need to have the patient blow off more CO2. You can increase the respiratory rate to whatever, 20, 22, whatever you think you can manage, and get that PO2 down to normal. And then when it normalizes, you can bring those values back down to normal. Okay. Now, sadly, as your patient's lungs become more fibrotic, especially with the COVID virus, as the lungs become more fibrotic, tidal volume and respiratory rate become less and less of an option. And you may find that even at a normal respiratory rate of 12 and a tidal volume of 5 mLs per kill, they may still have elevating CO2s. And at that point, if the lungs are really stiff and non-responsive, you may end up not being able to do much. You may have to allow that CO2 levels to climb, and that's what we call permissive hypercarbia. It's not ideal, but it's the reality of stiff lungs, and it's part of going with the COVID virus. All right, let's move on to the next slide. So this is the question. Let's go through the question I gave you at the very beginning. A patient with acute respiratory distress syndrome is on a mechanical ventilator with the following settings. So the FiO2 is 80%. All right, so now we know that's pretty high. That's well above oxygen toxicity levels, and it's certainly going to risk nitrogen washout. So, got to think about that. The respiratory rate's at 12, which is normal, right? That's what you and I are probably breathing about right now. The tidal volume's at 5 mLs per kill. Now, remember, 5 mLs per kill is, I mean, that's normal when you're not intubated, and that might even be a little bit on the low side for an intubated patient, anywhere from normal to a little bit low, 5 mLs per kill. And the peak end expiratory pressure is set at 15. I don't think I mentioned this, so I'll mention it now. Normal PEEP is 5. We PEEP ourselves normally at about 5. So 15 is 3 times above normal. So that patient's got quite a bit of FiO2, quite a bit of PEEP, but a normal respiratory rate and a normal tidal volume. Now, the blood gases you get back are pH of 7.33, which is it's close to normal, right? Just a little bit on the acidotic side, but that's not bad. A PO2 of 84, which is it's a little bit lower than I would like, but it's not bad. Certainly with an FiO2 of 80 and a PEEP of 15, I'd love to see that higher, but 84 is acceptable. Now, a PCO2 of 77 is, that's ugly. That's way too high. And then the bicarb is 16. I don't think I think that's 16, not minus 16. So your bicarb at 16 that's going to be a little bit on remember, bicarb is normally 22 to 26. So that's a little bit on the low side. So this patient is in just a little bit of a respiratory acidosis. There's certainly the respiratory side is screwed up. We can tell that from the PCO2, and the pH is just below normal, so that makes it a respiratory acidosis. Looks like there's a little bit of compensation going on there with that bicarb. So which of the following changes on the ventilator which would be most appropriate at this point? A, increase the FiO2? No, let's not increase the FiO2 because your patient has a pretty normal PO2 of 84 and their FiO2 is already at 80. Good night. We don't want to keep putting that up. We're just going to keep driving oxygen toxicity. So I don't see any need to increase the FiO2 with a PO2 of 84 and an FiO2 already at 80. So that one's wrong. B, decrease the tidal volume. Now, remember that tidal volume is already at the low end of normal. It's 5 mLs per kill, and your patient's got a pretty high CO2. And you want to increase the tidal volume to decrease CO2. So there's no way I want to decrease the tidal volume because this patient's already on a low tidal volume with a high CO2. So we would not want to decrease the tidal volume. So B is incorrect. C, increase the respiratory rate. Yeah, you guys, many of you guessed it right. That's the correct answer. Because remember, the faster somebody breathes, the more they blow off CO2. This patient has a high CO2. And then decrease the peak end expiratory pressure. Uh, you know what? We should not be doing that. Although we don't know this patient's blood pressure, there's nothing in the question that says there's a blood pressure issue. So unless their blood pressure is low, there would be no need to decrease the PEEP because we want to get that FiO2 down. And if I start decreasing the PEEP, their oxygen levels are going to tank, and then I'm going to have increased the FiO2. So you would definitely not want to do D unless you found out that your patient had some sort of a blood pressure problem that's not in that question. Ooh, that was a lot of information to pack in 45 minutes, right? But I hope if you have to care for patients in your ED that are being held during this crisis on a ventilator, that you have a little bit of a better understanding of how you can work hand in hand with your RTs to manage these patients' basic ventilator settings. I just want to give you a few tips here. Number one, you may have seen on our site, but we have made our ABG lecture temporarily free. Okay, so if you're not good at interpreting blood gases, we do have a 40-minute how to interpret blood gas lecture, and we've made it free to everybody. It's our way to say thank you for what you're doing every day right now in this craziness. So please access it if it will help you to take care of our patients better. It's free, and you can see the link on the website there. As I said at the beginning of this, we taped a ventilator module. It's 25 minutes long. Michael Hunix, a nurse practitioner from Detroit, has taped a more in-depth ventilator lecture than I just gave you, and we're going to be releasing that for free tonight. Okay, so watch on our website and you can get even more ventilator than I just gave you. We will also be reposting what I just taught for free. So I really hope that these things are going to help you feel better about caring for patients, and it's our way to say thank you to you for everything you're doing. Just so you know, this coming Thursday, we are going to be doing another free webinar on ARDS, acute respiratory distress syndrome. It's one of the syndromes that COVID patients go into, and there's a good chance you'll be caring for people with ARDS. So I'm going to offer another free lecture on ARDS, how to recognize it, how to treat it, and then how to manage it on a ventilator. And then next week, we are going to start offering our review courses. So CEN, TCRN, CPEN, and then our lab analysis course. We're going to start offering those online. We've had to take a little bit of a break from doing live courses around the country because, for obvious reasons. So, because people still need their CEs and people are still studying for their review course or for their certifications, we're going to start doing our review courses online. So watch our Facebook page, watch our Instagram page, watch our website. We'll be having information. And if you want to take our courses online, we'll be doing about 2 hours per week of each course. So you can join us online. Finally, in the comments section, let us know if there's other modules you would like us to do for free that would help support you during this crisis, like this ventilator module and the ARDS module. We would be more than happy to provide education to support you. You just need to let us know what you need and how we can help you. Thank you so much for being a part of this, and hang in there, everybody. It's tough times for all of us. I understand. I'm out there with you taking care of patients, but when we stick together, we can do this. And let me just give all of you a hand. Thank you very much for everything you're doing. Have a good evening.